Hi, my name is Kelly Morrow. I will continue to discuss with you my research proposal regarding clinical decision support, or CDS systems, their use within oncology, and specifically if they are reducing or exacerbating disparities in care. Decisions regarding cancer treatment options are some of the most complex choices in healthcare today. When a patient is diagnosed with cancer, there is rarely a single clear answer. Instead, providers must choose between multiple treatment options, each with different risks, benefits, and levels of uncertainty. These decisions are influenced by many factors, including patient characteristics like age, overall health, and pre-existing conditions, as well as cancer-specific factors such as type, stage, and aggressiveness. On top of that, provider experience, patient preferences, and access to care can all influence the final decision. Because of this complexity, clinicians increasingly rely on clinical decision support systems to assist in decision making. These systems analyze patient data and compare it to clinical guidelines in research to recommend treatment options. My original research question focused broadly on the role of CDS systems in influencing treatment decisions and outcomes. However, after reviewing the literature and receiving feedback, I refined my question to focus on more specific and more meaningful gap. Do clinical decision support systems reduce or exacerbate disparities in cancer treatment decision making? This question shifts the focus from general effectiveness to equity, which is a critical and underexplored issue in healthcare. The existing literature on CDS systems in oncology is extensive. Multiple systematic reviews have analyzed thousands of studies and consistently found that CDS systems generally improve decision-making, reduce prescribing errors, and enhance adherence to clinical guidelines. Overall, the literature shows positive impacts in areas like clinical accuracy, workflow efficiency, and patient safety. However, one key insight I found is that CDS systems tend to support decision-making more than they change behavior. In other words, they help providers make better informed decisions, but they don't always lead to long-term changes in practice patterns. More importantly, despite the large volume of research, there are several significant gaps. First, there is limited research on implementation, meaning how CDS systems are actually integrated into real-world clinical settings. Second, there is a lack of research on costs, long-term outcomes, and mortality rates. Third, and most relevant to my study, there is very limited research on healthcare disparities. Current studies do not clearly address whether CDS systems help reduce differences in care across populations or unintentionally reinforce existing inequalities. This gap is especially important because healthcare is not equally distributed. Factors like race, socioeconomic status, and geographic location already influence treatment access and outcomes. So while CDS systems are designed to standardize care, it is not clear whether they actually achieve that goal across all patient groups. Based on this gap, I developed a conceptual model with the independent variable being the use of clinical decision support systems and the dependent variable being the level of disparity in cancer treatment decision-making. The relationship I am studying is how CDS systems influence treatment decisions across different patient populations. My hypothesis is clinical decision support systems have the potential to reduce disparities in cancer treatment decision-making, but in some cases they may also unintentionally exacerbate disparities, depending on how they are designed and implemented. This is a two-tailed hypothesis, meaning I am not predicting a strictly positive or negative effect. Instead, I am proposing that the outcome depends on context. The logic behind this is based on several key ideas. First, CDS systems can reduce disparities by standardizing care using evidence-based guidelines. This may help reduce variability and minimize human bias. However, CDS systems may also introduce or amplify bias if the underlying data is not representative, certain populations are underrepresented in data sets, or the system is implemented unevenly across healthcare settings. Additionally, provider behavior plays a role. Even if CDS systems provide equitable recommendations, they may not always be followed consistently. So overall, the model reflects a conditional relationship where the impact of CDS systems depends on data quality, system design, and real-world use. To test this hypothesis, I developed a quantitative research methodology using a comparative observational design. This aligns with what we learned in the textbook, where research design should match the research question. Since I am examining relationships between variables and differences across groups, a quantitative approach is the most appropriate. More specifically, I will use a retrospective cohort study design. This means I will analyze existing data from cancer patients who were treated in healthcare systems that use CDS tools. I chose this design because it allows for analysis of real-world clinical data. It is practical and cost-effective, and it is commonly used in health informatics research. The study population will include adult cancer patients receiving treatment in healthcare systems that utilize CDS systems. I will use purposive sampling, selecting data sets from institutions that have implemented CDS systems, maintain detailed electronic health records, and include diverse patient populations. This ensures that the study focuses specifically on environments where CDS systems are actively influencing decisions. Data will be collected from secondary sources, including electronic health records, or EHRs, clinical databases, and cancer registries. From these sources, I will extract key variables such as patient demographics, cancer type and stage, treatment recommendations, actual treatments provided, CDS system recommendations, and clinical outcomes. These variables will allow me to compare how different treatment decisions differ across patient groups. To analyze the data, I will use statistical comparison methods. For example, I will examine whether different patient groups receive different treatment recommendations and whether CDS recommendations are followed equally across populations. By comparing these patterns, I can determine whether disparities are reduced or persist in CDS-supported environments. Because this study uses patient data, ethical considerations are critical. All data will be de-identified, collected in compliance with HIPAA, and reviewed through an institutional review board if required. This ensures patient privacy and responsible data use. There are some limitations to this study. First, retrospective data limits control over how data was originally collected. Second, CDS usage may vary between providers and institutions. Third, disparities are influenced by many external factors beyond CDS systems. However, despite these limitations, this design allows for meaningful analysis of real-world patterns. In conclusion, this research moves beyond asking whether CDS systems are effective and instead asks a more important question: who benefits from these systems and under what conditions? By focusing on disparities, this study aims to better understand whether CDS systems are helping create more equitable healthcare or unintentionally reinforcing existing gaps. The findings could help guide future improvements in CDS design, implementation, and policy, ultimately supporting more fair and effective cancer treatment decision-making. Thank you so much.